So good afternoon. Hopefully everybody's enjoying the ICE conference so far. My name's Dustin Telford, and I like the position here. It's not the first one where everybody's trying to get their feet wet, but it's also the one that I hate because it's right before the fun, if you will. So I'll try and make this a little bit more engaging, and talk through some ideas that I have, some actions that I've put in place in my career, and I'd like to hear from you all a couple of things. As I go along, I'll be asking you some questions, but I'd like to hear, first of all, your ideas at certain points, right? Or what you've done, what you've tried, what's failed, why it's been successful, and those kinds of things as far as developing your in-house imaging service capabilities. Now, my title was already long. When I say in-house capabilities, I do not mean that this is only for your direct employees of the organization. They may be contractors, such as an independent service organization, multi-vendor, whatever you want to call it along that stream, or an OEM. It's doing the right thing, hopefully for your organization and hopefully for your team. Consider that those engineers that might be managed by one agent, direct employee of a hospital, or they're the manager from an ISO and they manage your in-house team. You're all a team, right? You're all supporting something, in this case, imaging. Here's my first question before we get into the slides. How many of you are clinical, are caregivers of some type, radiology directors, managers, technologists? Raise of hands, I should say. None? Okay, well then this might make it a little bit more streamlined conversation. How many of you are service engineers? We've got a couple, okay. And that's good. That's really good. Take some of these things back, hopefully, to your teams. And when you're possibly looking at leading some teams, take some of those things back as well. Am I right in assuming, raise your hand if I'm not right in assuming that the rest of you are managers, directors, owners of some business that services equipment. Nathan, well, you're on the clinical side, really, right? More, even, okay, well, both, yeah, because I met Nathan briefly this morning, so I know a little bit of his background. Okay, let's get started. My background, I was thinking about this a couple of weeks ago. My background is roughly almost 30 years in the field of medical equipment. So I may say biomed, I may say clinical engineering, I may say HTM, and I will say imaging. Please forgive me if I offend you because I say clinical engineering and you're like, oh, well, that's that other group. This audience is here for imaging, I assume, right? So it'll be interchangeable in my language because I just adopt whatever the organization I've worked for or I've helped adopt their language. Some of the objectives today, or the objectives today, are to discuss understanding the value of why you want to look at your service capabilities and enhancing them, establishing that baseline. This will come into play about, why do you want to do this, but where are you at right now? Building partnerships. Again, I've kind of alluded to some of that already with ISOs, OEMs, but I'll talk in more depth about some other areas of partnerships. Planning for your future. How many of you are struggling, and you don't need to raise your hands on this, but with hiring the right people or retaining the right people because they are aging out, they're retiring. And then, of course, you can have all these great plans, but how do you measure your success? And that that I will tell you right now, that can't be on the number of PMs completed on time. It can't be on, you know, whether or not Joint Commission comes in and pat you on the back. As one VP I reported to said, Joint Commission's a C, right? It's a C average. You've just got to meet their standards, do more than what they expect, right? Don't even worry about what they expect because everything else kind of falls into place. We'll go over more in depth about these other categories, baseline plans, assessing your technical competency. I didn't put bullets on some of these in particular because I want to make sure that I don't highlight everything and give everything away so you don't read the slides. It's that it's interactive, hopefully. Assessing your inventory and planning, where your inventory is, where it needs to be, and then of course, more open format, hopefully time allowing for discussions. So you all have some paper on your desk, and I wasn't particularly going to do this, but I'm going to ask you all to take a moment and write what your organization's mission is. And if you can write down what its vision is, even better, bonus points. You don't have to share these, but if you can't articulate your organization's mission, I think everything else is going to kind of fall out of place, right? You're not really going to get it. And I don't mean this presentation, but the next steps. So if you can write that down, or even if you want to think it in your head, I see some people that I'm sure know their mission, but they aren't going to write it down. I'm going to call out Chris there. I don't even know if he has a piece of paper in front of him, but Chris Nowak, I'm sure knows his organization's mission. And it doesn't have to be your healthcare organization that you might support. It may be that you are a independent or another division of service. The next thing is not your mission, not necessarily your mission, but why are you in business? If you're the manager or director of I'll call it an imaging service group or a clinical engineering department, why are you actually in business? What keeps you in business? That point is probably more important than what the mission of your organization is. Honestly, I've walked into departments where they don't know why they're in business, or they don't run it like a business. And honestly, an in-house program, probably best way to put it is they're there to hope that nobody thinks they're spending too much money, right? Cost avoidance, savings. If you're a vendor, you may want to obviously be competitive as far as pricing, but you may add something else as far as why you're in business for the C-suite on the financial side. The CNO, if she's like my former CNO, wants both cost effectiveness and patient care. But you've got to know why you're in business. And you've got to put that down and articulate that in a business plan, not your medical equipment management plan. I know I thought that was the solid gold process for probably the first 6-8 years of my career. I thought, well, we're doing all these things, right? Or we have to do all these things. That's not a business plan. Now, I'm going to move ahead to who, and you can read these. Who are your customers? Who are your key customers? I mentioned your C-suite. Your C-suite usually holds the keys to a lot of your success, right? Or the C-suite at your customer site. They're going to hold the financial responsibility and accountability, really, for whether or not you have business there in the future. If you have the right number of staff, if you think that you're an in-house program and you're safe, you're still going to have to justify it. And then you need to think about who your direct and your indirect customers are. I will spend some time on customers in this presentation. And I'm hoping that the rest of you get this, but one of your key and most important customers is your staff, is your team. If you don't support your team, if you don't support the vendors that are coming in, they are less likely to align with number one and number two, your mission and why your business is there. And they'll leave too if they're an in-house program. And yes, sometimes ISOs and OEMs part ways. That's why they have in a lot of their contracts, they've got an out clause. Even if they don't want to give you an out clause, they may have their own out clause of, you know, it's just not working out. Now, the last point, I said something about the C average for the Joint Commission. These are all, the first three I think are fundamental. But the fourth one is, how do you actually provide excellence? And what is excellence? And I'll tell you my thoughts on what kind of plays into excellence, some of the factors that play into excellence. But you need to ask yourself that question at your organization. Up until recently, I worked for a children's hospital, and I was wearing these like generic masks. Somebody in our church made, they looked like the surgical masks, right? And then I thought, well, I'm working at a children's hospital, right? Now, although this isn't excellence, I figured I'd have some fun, some more fun masks to wear while at work. It's those little extra things, and sometimes it's those big inspiring things that set you apart as a business, again, in your hospital, to your customers if you're not part of the hospital itself. But it's also, you can't go higher than 100% on PM completions, but you can figure out how that quality of your service program increases, right? And each vendor has their own little spin on it, whatever. Dave is on his phone right now, but I'll call him out here. He mentions this in the past. I've heard him mention this, and it is vitally important that you need to distinguish yourself, right? Because TKA, right, Dave? TKA has probably something that distinguishes them from the rest of the crowd. And it's probably not price. It's probably something else, right? I don't know a lot about TKA, so maybe we can talk. We could go into that microscopic level, but I like the visual too, and I'll give you a couple of visuals. Think of this as kind of the 3D, right? The glasses. Those points that I bring up, each of them are components of a 3D picture, right? Something that you can see. Possibly if your customers, for example, if the first thing that comes to your mind, which a lot of us do, I'll admit it's me, my customer, even though it's an indirect customer, the first customer that comes to mind in a healthcare system is the patient, right? My direct customers are probably the imaging service techs, right? I'm glad the directors aren't in here right now necessarily, because they might be offended by that, but they're the ones that know what's going on with their equipment. But if it doesn't align with the mission, right? If you don't figure out how that all aligns, like Children's Hospital of Omaha, their mission is to serve every child. That's kind of a broad statement, right? But if your mission is there, where do you set your goals, right? You have to be able to respond to that. So they're building a new building, right? There's more people in Omaha than there were 20 years ago when they built the first one. But think of it as a 3D lens. So I could take, say, your business and your excellence, if you've got everything, and that, again, the little visuals, I picked these icons. I thought, oh, that's kind of representative. Business can be a bunch of boxes, a bunch of elements that all kind of tie together, and you deliver a service or product or both. But what's the excellence factor, right? That's part of your business. It may not be part of all those boxes. It might be the disruptor. And I'm not very photogenic, so I just realized that. Anyway, now, how many of you, actually, this could be a loaded question, so don't raise your hands on this, but think about this. How many of you love what you do, right? What you do today? And some of you are raising your hands because you really love it, right? How many of you love something else you used to do, or you think the grass is greener on the other side? Whatever that is, ask yourself how you got started, and then why that's your new thing, like why you love what you do. Again, I know a little bit of history for Chris in the back. Chris was one of the folks that raised his hands, and I'm glad that he loves what he does. But I also know, because he shared with me, that at certain points he struggled, right? Not with what you do today, but he struggled in the past with, like, what's the motivation? Why am I here? But he started someplace and got to where he is now, and he loves it. How did you get started? Did you start as a technician? Did you start well, I have a buddy who was film studies major and decided to change careers, and now is in biomed. You know, so how did you get started? What keeps you coming back? And hopefully, you know, the pay is okay, but eliminate that. And I really don't want you to think about that, because the paycheck, you can get the paycheck someplace else. What keeps you coming back? And actually, if anybody'd like to answer this, this is a good point to hear. What keeps you coming back to work? What makes you excited? Do you get out of the car and say, I'm here and this is what I'm going to do today? I'm not asking you what keeps you up at night. That's a different question. New challenge, new customer challenge, new experience. I like that. I like challenges at work. I had one coworker of mine once say to me, man, you really seem to like these challenges. Like, yeah, a little bit more my thing. You in the back. Knowing that you make a difference, like how? That's good. That's good. I posted something on LinkedIn a couple of weeks ago, and it's like got all these views and all these comments and stuff like this, because I thought, wow, this is an amazing story. There's a variant engineer, I think in Missouri, that it was just highlighted that he had the personal opportunity. He was already the engineer for a LINAC that his, I think 5 or 6-year-old had to use, because his 5 or 6-year-old has cancer. And a lot of the comments on there were like, this is why I love my job, right? And this is what we teach at some of the colleges and at the Army program or whatever. We teach people, we hope that they get this. So we say, well, what if your family member is using that medical equipment? So there's all sorts of motivations, right? Anybody else want to share a motivation? Now, I don't think this Varian guy, by the way, I know he probably never imagined that a LINAC was going to be used on any family member. I mean, we have all probably known somebody that's been affected by cancer, but how many people can say it was LINAC was used, right, in their treatment or therapy of their family member? And this is his son. Anybody else? Any other like awe-inspiring moments? Okay. And I guess I kind of already hit on this, but why do you care? I put this in here, like, why do you actually care to do your job? I've worked with a few folks that it is about the paycheck, and I don't think that's really about caring about their job. It's caring about, you know, putting bread on the table, and that's a very admirable goal. But I've also known those same folks to be the ones that are less excited about the challenges, right? Less connected with like providing a good service to healthcare. Probably would kick it into higher gear if their family member was coming in for a surgical case, or if they knew ahead of time that they were coming in for an MRI and they were the MRI engineer. But they really don't care. Where's the heart, right? What do you do? And that's a real thing to ask, a real good question to ask of yourself. What's your story? Where did you start? Why do you keep coming back? And why, or do you care, for that matter? If you don't, I know we're short on people in this industry, but maybe get out, do something else that you care about, right? We talked a little bit about mission, but I'm going to go a little bit deeper in this. Your mission, just like Children's in Omaha, their mission is to, right, care for every child. And of course, we can't do that completely, but you're talking about the area, right? And then some adjacent areas when they get inundated, high census or whatever. But what type of care do you provide? I had the privilege of working for the VA. I connected with that quite a bit, not only because I was a veteran, but because even if I hadn't been a veteran, I felt like I was serving the veteran population, right? I mentioned Children's. You can see there's the type of care you provide is pediatric. So I joke with some people that particular children's hospital doesn't have a mammography unit, but I do know some that do, right? And that's teenagers, right? That usually need that mammo visit for reasons. But the big thing is, how does it affect your particular community? If you're a service vendor, which I know some of you are, how does it affect your local community or the communities that you do business with? If the healthcare system is broken in a community, that community probably suffers some other effects, right? Schools, government, police. Poor health contributes to a lot of things that you wouldn't not necessarily want to see in any community. I know we in this room serve a very small aspect, we think, sometimes in healthcare. But with the growing number of medical devices in the, and I mentioned this, almost 30 years I've been in the field, I don't know how we can deny that of all things, thermometers became very, very important because of COVID. Like, so important that it was like, how many thermometers do we have? That was the first question that I got asked. How many thermometers do we have? Where are they? Right? Who has them? And do you think you can start negotiating with those departments and saying, hey, you could use a few less thermometers because we got to screen everybody at the door and at every clinic and blah, blah, blah. But the number of medical devices equates to something, especially if, let's say, you have a good program, 1%, 3% of them are down at any given time for some sort of service, preventative, scheduled stuff, or unscheduled. But it impacts the community too, the quality of that. That's not only the service, but you're planning on what goes into those communities. How many of you that work for healthcare systems or provide services to the healthcare system. See, the healthcare system, the main hospital, the flagship hospital, gets the shiny new toys, I'll call them. And then the clinics in the rural communities usually get, and I know I'm kind of loading this question, get the hand-me-downs. I see a couple of nods and stuff, and I know I kind of loaded that because I've seen that way too many times. The vice president of children's physicians, I sat down with her and I told her, we've got to stop that philosophy with children's physicians, right? They had some pretty decent equipment. I think she had thought about it for years, but then had a backer, right? Somebody to say, you know, I'm going to look out for you too when I'm on the capital equipment committee. Just a couple of quotes about your business. I'm not going to tell you how to write a business plan. If you want to talk about writing a business plan, there's plenty of examples out there. I don't think in our industry we all think of this necessarily, and we don't think about what elements go into the business plan for your organization. And I really mean this. I think this is a shortfall for in-house programs. But I love these two quotes, so I put them in there, except for my wife got this. She was looking at this the other night. She's like, oh yeah, you messed something up on the slide. So the first quote is actually supposed to be, far and away, the best prize that life offers is the chance to work hard at work worth doing. That goes back to, you know, how did you start? Why are you in business, and what keeps you coming back? The next one is, there are no secrets to success. It is the result of preparation, hard work, and learning from failure. The first part of it is probably more important. We all hopefully learn from failure. That's key, hopefully, because we have to be resilient. But if you're not preparing, if you're not putting together a business plan, I will keep mentioning this, and it's too bad I didn't just give the presentation on this necessarily, but put together a business plan for your organization, put together a strategy for who is going to be replacing you, or what type of person is going to be replacing you, how you're going to pay for the raises that you're hopefully giving your employees, how you're going to pay for the training, and we're going to talk about this, right? And if you were to market your business to your CEO and you're an in-house program, what are your distinguishing factors, right? Just saying you're doing joint commission, I can tell you there's several people in this room that I know could come into that room and say, well, we can help you with all that joint commission stuff. And we can do that distinguishing thing, right? But prepare and do what you love, right? You've got to know why you're in business, do it well, but you've got to prepare for it. How many of you felt like you were underprepared for COVID? I didn't know necessarily. Did you kind of feel a little underprepared for what changes were going to come from, or all the changes that probably came out in every organization? For the first couple of months, how many people had, like, if you were a manager or director or VP, you were told, okay, so we got to do this, this, and this. Communicate it to your staff, right? Communicate it to your staff is probably not even the best way to do it, right? Talk to your staff, listen to them, see what their thoughts are. Some things are going to change, and some things we need input on. But how many of you felt like you were prepared for COVID? Truly. How about masks? How about masks? How many of you had engineers who said, mask, I can't even do my job with a mask? Nobody? I'll raise my hand on that. I had one call him sour apple, that every time he could, he took that mask off. And how it got back to me was it made some of his coworkers feel uncomfortable because they didn't know what to expect. How many of you had your engineers have family events that needed to be taken care of, or family care that needed to be taken care of during the major increase in COVID infections? What did you do? How did you handle that? I mean, you picked up the slack and allowed them the time. I'm gonna share with you guys that I don't think anything could prepare me, even though I have worked at organizations where a technician has passed. But nothing truly prepared me for what I knew was going on, because it was being shared with me by one of my employee's sons while he was struggling with COVID, and he eventually died. We can't prepare for everything, and that's not going to be in your business plan. What happens if somebody dies? What you know, you're probably not going to put in your business plan, hopefully, what happens if somebody retires, which is more predictable, or somewhere in between if somebody decides to take another position. But you've got to think about how it impacts your people. And I can tell you, it impacted me quite a bit, but I knew it was going to impact my guys much more than me. I shouldn't say much more, that sounds kind of, but I knew it was going to impact them in a way that there's the obvious. We're going to have to pick up some slack until we figure out if we're going to be able to replace the position, who's going to fill those shoes. And I'm going to bring up Gary a little bit in this conversation with you all, because the best laid plans, business plans, Gary was part of this plan. Gary was part of the development plan that I had. Gary was a seasoned engineer with 40+ years of imaging experience, friendliest guy. I knew the day that I met him, right, for an interview, two things. Like, I don't care that he's old. That's one thing I knew, because I could see it on his resume. I was like 40+ years. But I also knew that he was part of a bigger plan. I knew that he would be the person to bring in and mentor, foster, train some of my newer techs, or those ones that wanted to get into biomed or had the potential, or into imaging, that were already biomed. But that wasn't written into my plan. And we had Gary for 1.5 years, and he passed. I'm going to talk about your customers here. I mentioned something kind of as a precursor. Staff are your customers. So I'm going to probably start the wrong way, right to left, the way you guys are looking at it. Staff, staff, staff. Your staff. They're your customers. If they're coming to you, if you're not going to them, I know virtual rounding is a thing now, but if you're not going to them and you're asking them, what can I do for you? You're not supporting them. There's a key part of your service as a leader, and most of you, it sounds like, are leaders in this. You're not supporting them if you're not asking them and really listening, and then trying to figure out if it's, I will tell you honestly, sometimes there's a, you know, an ask that's so big or so unreasonable, and it probably isn't going to support them, that there's some other solutions that have to happen, right? I had one that said when he was hired on, he was told he'd learn everything about biomed at the hospital. I said, we just don't have time in the day. We have all sorts of training opportunities. We have all sorts of OJT, formal, in-service training. But he took it to the point where it had to sit down. We had to sit down and say, we're not the College of Biomedical Engineering, right? Because he wanted to spend 100% of his time doing that as opposed to doing his work. And I'm like, well, probably wasn't a good fit. The caregivers. I told you I was going to go kind of backwards on this, at least for most of you who read left to right. The caregivers, obviously they're your customers. It can be the radiology director. I mentioned the radiology director is not the first person that I usually think of. I certainly need their buy-in on certain things, but the caregivers, the nurses in radiology, the radiology technologists, those sonographers, everybody in that caregiving spectrum, they're a key customer, and they're your direct customer besides your staff. And then I'm going to get to the patients. How many in this room have had to go through some sort of training about, well, some organizations will call it AIDET, AIDET, or they'll go through training that's called language of caring, or delivering that wow moment. I've worked for a couple of different healthcare organizations, and they all have something. As a matter of fact, the VA had, and this was very good. It was odd to me, but some VA employees don't realize they work for the VA necessarily, and they support veterans. So they had, I think, an acronym called CARE or something. I can't remember what it was, but it was about caring for those people that serve or have served our country. But how many of you have gone through some sort of program like this where you have to kind of be reminded that there's these patients in the facilities you're in? Have you had to go through that? I know you've kind of. Well, anybody else? I don't want to keep picking on this corner of the room. Nobody's had to go through any, and I say go through because I will tell you that a lot of this training, what I see is technicians and engineers and even their leaders think, well, I'm not a frontline caregiver. Why do I need to be touchy-feely with these patients, right? Wrong mentality. Wrong mentality if you're working in a hospital. It's really easy at a children's hospital. I'm not the best at it, I'll tell you, but it's really easy at a children's hospital to connect or to go, oh man, that kid's the patient, right? Because the other two people are adults and they must be guardians, right? It's just, there's somebody else. That kid's the patient. And it's pretty easy at a VA to figure out who the veteran is. Not to sound sexist or whatever, but if there's a husband and wife looking duo, you can usually guess it's the husband, especially since usually what I saw at the VAs was the wife was going, okay, so now here's your next appointment, right? She was still running the show. But if you haven't had to go through that training, which I'm really surprised because these have been around forever, look at that. Look at that. If you're an independent service organization, if you're a healthcare group and your clinical engineering, HTM, biomed, imaging service group hasn't had to go through this training of whatever flavor your organization has decided to purchase, ask if you can attend, if all your guys can attend this. There will still be some people that'll say, What? I'm not a touchy-feely person. Remember, ADIT stands for acknowledge, introduce, describe, explain, and then think. And one of the standards was to go up and this is at the time, this wasn't too long ago, but to go up and put your hand on the patient. How many imaging service engineers feel comfortable going up to a patient and saying, hey, how you doing? I'm here to fix your medical equipment. Well, technically, if you're following the rules, sir, name, whatever, Dan, I'm Dustin. I'm here to fix your medical equipment, right? I'm gonna do this. Is that okay? Thank you for letting me do it. You don't have to actually physically touch the patient, but what you're doing is you're connecting with the patient. Now, going back to pediatric, I will mention this. Pay attention to the kid more than the parent. If you're the biomed, the parent usually appreciates that a lot more than you going in and going, hey, I'm just gonna talk to you and that 8-year-old who can probably comprehend exactly what I'm doing too is, not understanding. But the patient focus, as far as your customers, if you haven't gone through that training, I'm really surprised at this. Ask your organization why you haven't gone through that training, because I'm sure they probably have it. If you're a independent service provider, maybe an OEM, maybe, you may not have had a patient-focused training. Look up ADIT. ADIT, I think, was very good. Language of caring, even more comprehensive and not just patient-focused. But look up a program and get your staff to do this, because it goes back to, why do you come to work? If it's just for the paycheck, I said, admirable goal, puts food on the table, but it's not going to keep someone excited, even if the challenges are good. So yeah, I remembered that, right? That if the challenges are good and you don't know why you're doing it, you're not going to be able to connect the dots, probably, of saying, well, that challenge, I did that, so it helped this veteran, this child, this cancer patient, this guy that came in for bariatric surgery, for that matter, right? And he's recovering well because everything went right in that room. I mentioned too that I'd mentioned something about excellence. These are my 5 main bullets for excellence. The first 3, the quality, reliability, and safety, I think have always kind of been me inherently, and I didn't mean to tap the mic there. Sorry about that. It wasn't until sometime, I will admit, probably early 10 years into my career, that I realized that there was this factor of cost, right? And it wasn't really until I had that first civilian true leadership role that it was about engagement. I kind of did this okay, I think, this engagement part with my customers, but what this encompasses now is engaging your employees, engaging not just your customers and saying what decisions should we make together, but asking your employees to do this together. Anybody have something that really describes a key metric or something that you should be measuring that would be excellence in this room? Anybody that can add to this list, or something that's repeat repairs? So I put that under quality, right? But repeat repairs, yeah. If you've got repeat repairs, what's that an indication of, Chris? Yeah, did you get my slides before this? Because I actually think I left that bullet in there a little bit, but repeat repairs, Excellence, anybody? What's an indicator of not so excellent, like repeat repairs, right? Or need some investigation maybe. Or true excellence. Downtime or uptime, or however you slice and dice it. And you know, what company are you with? Well, it doesn't matter. Oh, sometimes our service providers will tell us we've got a good downtime policy, and then they like to slice and dice it and say, well, since your coverage isn't on Saturdays, we met our goal, right? We can get into metrics, but how you measure that quality, make sure you're consistent, make sure you understand what you've agreed to with your vendors. So if I can repeat it, because I forgot, I should be repeating this for the WebEx part. You're saying customer surveys demonstrate excellence because they can take in a lot of factors about what's excellent about your program. Okay. I could not agree more, with one exception. I'll tell you, those surveys don't come out frequently enough. It's the magic moment, and I gotta pause for a second here on this. It's that magic moment when you get unsolicited, positive, glowing, and well-written feedback or verbalized feedback, for that matter, about one of your employees, right? Or about your not just one, maybe it was a team and they did something. Because the survey, I've got to wait for the survey, or it's after a service event, or it's quarterly, or people aren't necessarily thinking at that moment the same thing they were thinking a week ago about whether or not you were good or bad or whatever, or average. So that's where I sort of disagree. I do the surveys. I do the surveys. I think they give an overall picture. But the reason I paused a little bit on that before saying that magic moment is we've all probably worked with that one person that goes out and seeks out that unsolicited feedback. I shouldn't say unsolicited at that point. I've had people that I've worked with when I was a technician, and I have had people that I've managed who have, it's like obvious, right? It's quite obvious. They go to the department head or they go to this nurse and they go, hey, you put me in for, well, one organization is called the Spotlight Award, right? You put me in for the Spotlight Award, right? So just a impromptu award recognition. They put them in, and it doesn't, to me, it doesn't demonstrate as much excellence as that magic moment where it's like, what? You know, I actually ask people, not for me, but I hear them say it on the floor, and they'll go, hey, your guy was great, he's fantastic, he's always on the ball, da 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 da. I'm like, take a moment if you would, you know, if you can. And I usually am persuasive enough. 5 minutes later, I'm getting it on my phone. Some nicely written, you know, the person's great. They didn't just verbalize it. Means a little bit more, I think, to the tech. I just don't tell them usually that I had to ask the customer to write it up. But excellence, quality, already hit on it. Quality is certainly measurable as far as repeat calls, performance indications like how many PMs did you get done. Reliability is how reliable your service is. Uptime actually plays into that for me. Some people would put it into quality. Safety, safety is kind of broad, I can tell you, but it's still measurable. One of the things that I measure is our response and our management of recalls and cyber threats, right? Safety also goes into this level of, are we actually managing proactively those things, the the recalls, right? Are we the ones actually reporting it to CRES that maybe there's a problem with the system? Cost, lots of factors in cost. Break it down, stay in budget. That's all I can say without belaboring the point. But engagement, I told you, it's key. If your staff don't have buy-in with you, they're going to go someplace else. Maybe in their head, maybe they don't feel comfortable going out and applying for another job, but they're checked out. And one of the most valuable things that we can have in any organization is a lot of minds putting our heads together. Now, there was a lot coming out with COVID, but one of the first things that I did, good or bad, is I sat down virtually with all my staff and I said, I'm going to prime this a little bit. Here's what I think we need to think about. Here's what's probably going to come from this. What do you guys think? And what do you need? So I had employees who said, I don't feel comfortable wearing like the same clothes that I come into the hospital with, working all day and leaving. I'm like, great, cool. You want scrubs? We'll get you scrubs. I had people that said, I hear that adults are more affected by this. What does that mean for us? We did a little brainstorming around that. We said, well, we're a pediatric hospital, but if that's really the case, and they get inundated like they were in Italy, this is about the time that Italy was, like, you know, we've got the same Philips patient monitoring, right? We've got the same CTs, and it's a possibility. So we investigated that, and we partnered with UNMC to understand what adult profiles they had in case we needed to load them onto rooms. Fortunately, children's didn't have to do that, but we came close. We came close to getting that call. And before our chief medical officer said anything about this to leadership, we were already prepared from clinical engineering standpoint because, and I truly believe this, is because we asked the whole group what they were worried about, what they thought, was it worth investing the time in, right? That one that I just brought up about patient monitoring was like, well, do we invest the time in it? Let's keep it in the sandbox and let's invest the time in it. A little later, hasn't hit Omaha, hasn't hit Nebraska significantly yet, but good idea, right? We didn't eliminate ideas, but that's a piece of engagement, right? Another piece is certainly letting your department know and buy into, hopefully develop with you, your business plan. So for baseline, I'm not going to give you all the magic science about where you get this, but look at your current performance. Are you completing your PMs on time, right? How many repeat calls do you have? How many corrective maintenance calls do you have versus preventative maintenance calls? I believe firmly that a good preventative maintenance program will start to see a trend, and I've proven this, that you put more time in PMs, you have a lot less time on correctives. And I don't mean take a 4-hour PM and make it 5 hours. I'm not saying that. I'm saying do the quality on the PMs. Make sure that you're doing what is the right thing for that equipment, the right thing for the environment that that equipment's being used in. But performance, measure where you're at before you start anything on this process. Measure where you're at financially. If you don't know where you started at, it's going to be really hard for you to explain to the CFO how you're avoiding costs, how you're going to save them money if you come in and help and support their program, or the COO or the director of IT or supply chain doesn't. Did you once report to supply chain, Chris? I can't. I did. But you're going to have to prove it to somebody. You just may know who that person is now, and you may not. But at some point, Take your baseline and take it, if nothing else, if you don't already have a baseline, go back. Figure out what your performance is on the simple things, right? Brainstorm a little bit and say, hey, do I need to measure some of these other things? Because I want to know where I was today and where I will be. Survey results, thanks for the plug at the back of the room. Survey. That can help you establish your baseline too. Now, one of the things I like to do is I try to meet with every department when I start in a new organization. I try to meet with at least the heads of the department and ask them what their challenges are, what their perspectives are, what they love or whatever about clinical engineering. I was privileged at Children's to walk in there and they said, oh, these guys are great. These guys are great. But I didn't hear why in some cases. Or I heard they're real friendly, but I didn't hear like anything measurable necessarily, like they seem to work around our schedules and do the PMs, and I know our equipment's safe. And then I ran into one director who said, man, we go through this every year, but we don't know what our baseline is as far as our equipment inventory. We get asked by finance what we want to plan for in the future. Can you help us with that? Don't do what I did. I told her, oh yeah, sure, no problem. I've got lots of experience helping with capital planning and da-da-da-da-da. We can help you. I should have been talking to finance before to figure out why there was a gap. So that took a little longer, but we figured out. I did uphold that commitment. It just wasn't the first year. Staff development. This is still broad. I put the brain picture on there. Left brain, right brain. You've got to develop them all the way. I mentioned patient experience training. It could be soft skills training like that. It could be soft skills training as far as effective writing or communication. We are obviously here more for the technical, right? The more tangible, we're going to pay somebody to do it, or we're going to train somebody to be the trainer. But staff development, take it as a baseline. What are you guys doing, right? Are they really good engineers that haven't had any sort of training invested in them in a long time? Is there even a plan, for that matter, on using the training? This was Children's. Materials management director says to me, she says, one thing you could help me with is we get all these vouchers for training, and I don't think Biomed's using them. I don't think they're using those. And I'm like, well, we're going to change that. I'm very pro training. And establish, if they're not already established, what your baseline metrics are. And take a measure. Take a measure for the last 3 years, for that matter. Your PM compliance, you got to look at least a year. If November is a bad year or a bad month, look at November and ask the question, why is it November too heavy? Everybody's taking vacation, right? Your plans should be aspirational, but not too aspirational. I have a tendency to do this sometimes, but I'll tell you, pick one. Pick one a year. Now, you may have an aspirational goal that's 5-year plan, 10-year plan. I haven't done a 10-year. I've done something that's more like a 6-year, but not even past 7, I don't think. 1, 3, 5 is usually what I try to do. But your aspirational goal for the year should be one goal, right? Some people would call it performance improvement goals. That's kind of a old school Joint Commission deal. But have an aspirational goal. What are your new initiatives to get there? And what are your key metrics? So since we're talking about training or developing your service capabilities, it's not just about training. And what are your key metrics? Your plans need to be able to measure how you're doing successfully to improving your service capabilities. And it all, let's keep it in the, reframe it in the mindset of what's your aspiration? Do you want to bring services in-house? Do you want to, You want to save $2 million next year in total costs and services? Do you want to improve your employee engagement scores because everybody's leaving that was good for something else? What's your one big thing? And there's the visual. Your aspirational is your heart into it. Hopefully your program's heart into it, and hopefully your customers' heart into it. When I say program, I mean your staff. Your new initiatives, we'll get to here in a second. Aspirations, I've already mentioned this. Don't do what I've done. It can be really exciting for a guy like me, but if you take on too many aspirational goals in a single year, it winds up being you're spending a lot more time, especially if you're a salaried employee. How many people have done this and said, well, I've got this, this, and this. Try to be smart about it too. If somebody else is going to set something that's pretty lofty for you to begin with, see if you can make that your aspirational goal, right? But if you've got too many things on your plate, hey, we all learned lessons. I will probably speak about it today, and I won't learn this lesson. I'll do 2 or 3 things in a big year, and still happens, right? But what's your big idea? What's your big idea? And get buy-in for it, right? Nobody's gonna help you with it. New initiatives, we're talking about the training part or the capabilities part. Are you gonna have a centrally managed budget? Did you have a centrally managed budget? Did Cath Lab, are they the outlier, or is every department paying for their own services and you have to go and request funding from them, right? Are you an outside vendor who does a pay for service kind of model or service contract model, but doesn't say, well, you know what, we'll take on a greater amount of risk, and that's a centrally managed budget too, to a degree. If they hand over the keys and say, well, if you think you're that good, make sure you do this. And that's the same thing you're doing as an in-house person is when you say centrally managed budget. You're saying, I can manage that budget better than you can collectively, or I'm going to take the risk and I'm going to take the hit. Are you going to convert your contracts? These are just questions. These are just some things that I've done. And we could fill a list with stuff that you guys want to talk about here, but you're going to convert your contracts to something more, something less. What's the right size? Are you going to just phase them out? I've heard this term. I didn't use it, but I've certainly done this. Biomed to imaging service engineer or field engineer. Matter of fact, I think it's Tri-Imaging has kind of coined the phrase a little bit recently. They've got a biomed to imaging service engineer training program. Pay equity and scalability. One brief note on this. And I recently almost got into a little debate on Facebook about this with some Army biomeds, I think they were. They said imaging engineers deserve the difference in pay than their biomed counterparts. And I am going to make the distinction between general biomed and imaging in this case. And I said, well, it's not what we did. But I should have probably been clear about this. What we did is I went to HR and said, hey, I'm not really familiar with the Omaha market. I've done a little back end research with some of the directors around here and stuff. But are our guys being paid well enough? Can I ask this question? And that was one of the first things that I really took on as, and it wasn't aspirational, but I took on. We wound up getting everybody's pay raised, which is good, right? Doesn't always happen, but we kept the positions as Tech 1, 2, and 3. Yes, an imaging service engineer is likely to come in as a 2 or a 3. A general biomed or an entry-level person is going to come in as L1, but they can all achieve a high level of pay within those ranges. And I'm quite proud of that, because then I can take somebody who isn't motivated just by money, who says, I really want to learn about imaging. I'm like, well, great. Why don't we send you to the CRM school, right? Why don't we start building you up? And I know some of you probably just looked at me and said, well, you're going to send some new guy to CRM school? It's a school, right? I can help backfill some of those other stuff. One thing actually I haven't done, but I know some organizations that have done this, is they've actually trained their radiology technologists not only to be field service type engineers for themselves, like they'll send them to the school, right? They won't expect them to service all the time, but what they found on radiology is they find that some of those technologists are a little bit better at troubleshooting their own problems before calling the in-house or the outsourced biomed. Now, back in the day, I attended a ventilator training as a technician, and I think there were 7 of us in the class. I was the only biomed technician in the class, and then UCLA at the time, it was all their respiratory therapists. And why? They said their biomed program kind of sucked. They didn't know what they were doing, and they figured they'd go to the training, and they'd been doing this for a while. It sounded like this is just another training. So I think it's a good idea, depending on how you're going to use those staff. Has anybody thought about where your imaging engineer should report? Has anybody had their stellar seasoned senior imaging engineer and you gone, well, I can't pay him well enough in my biomed department, but and I'm going to go here, if I transfer them over to radiology, they can actually achieve a higher pay scale? I've seen that a couple of times. I've seen that actually with the VA, not the VA that I worked at. I've seen that with the University of Utah, and it makes a heck of a lot of sense, right? Transfer them over to those folks, but in both situations, they technically still were managed by that department, but they reported to the in the VA system, the biomedical engineer, right, as they call them, the University of Utah, the biomed supervisor. They still reported to that person for operational stuff, but they got a better pay scale, right? And they were more aligned. And the last thing I'm going to mention here is on this is hybrid sourcing solutions. Like, what are you doing that if you're not thinking about your service capabilities going straight to in-house or straight to an OEM, I want to plant this seed too. Yes, there's middle ground of like some stuff's on contract, some stuff's not, some stuff's on time and materials, or you'll manage it. But why aren't you considering going to the Crochels, the Trimedics, the Renovos, the UHSs, whatever of the world, and saying, hey, you guys have a certain level of expertise and the back end office and everything else to support an imaging engineer. My program is focused on all medical equipment, but could you place a person here? The Army does this, and some of the VAs will do this occasionally. They'll hire somebody else to come in and be part of the team, but they are actually an employee of maybe one of those companies that I mentioned, or another one. I didn't mean to exclude them. Oregon, I think, had Philips engineers on site, Oregon Health. But that's what I mean by hybrid sourcing. Like, don't try and do everything, right? If it makes sense and that's where you want to keep it. It doesn't have to be part of a transition plan to bring it in-house. I've worked at that angle too. I have actually worked at that angle and said, but my intent is to eventually hire that person. So, let me interview the person that you're going to place here. Let me negotiate right now what it's going to cost me in addition for you to really kind of headhunt this person for me or provide your engineer over. They'd be happier, I'd be happier. But I'm talking about placing your engineer here. And I will say this, because this is recorded, I don't want to like offend a particular OEM, but I did have an OEM say to me in a joint meeting where we were going through red lines on a master service agreement. They said, well, it's great. I understand that you want to train your engineers and stuff, but we can't possibly agree to this red line to take the statement out that they have to be your employees that'll do the work and will receive our training. And I hadn't done any background communication or anything with the executive vice president in the room, who was key to that whole partnership with that OEM, or my VP for that matter. My VP and I hadn't really talked about what I said next. But I said, listen, I don't have any intent of outsourcing my program because I'm the first guy that goes, right? I'm the manager of the program. I'm the first guy that goes. They'll put in their own manager. I don't have any intent of that. I want to run the best. But if the best thing for the organization is to have the imaging engineer or engineers be a third party, and at the time, the only one that I could think of was Aramark. I know Aramark is kind of now part of somebody else. But I said, let's say it was Aramark. I want the best thing for the hospital. Remember why you're in business, right? Sometimes you got to make some decisions as a leader that aren't necessarily the things that are going to keep your job security. And then the next thing in that room was a lot of clatter from the OEM side. Whoa, we can't possibly consider that. I said, well, I kind of know you can. I've been around the block. We actually did this at another hospital, but I'm not going to disclose the business that we had with this other hospital system. But you guys worked with me there, just different managers, different directors. This is either a deal or not a deal, and they clatter. And then the executive vice president, who I had very, very little contact with him, speaks up in the room and he says, one of the best things you want to hear if you're an in-house program. He goes, I have no intent, tells the OEM, I have no intent of ever outsourcing the biomed program here. But I understand what Dustin's doing and I support him fully, right? The first part of it was the thing that I really was like excited about. I told people about it after the meeting. I'm like, good. Now, what new initiatives have you had as far as training, capabilities, how you're delivering better service than you were today? Anybody? What's a distinguishing factor of your business, right? What do you claim if you come into a new business opportunity, for that matter? Those of you that are service providers. These are just some of my thoughts. Write them down, brainstorm them, talk to people at this conference for that matter, talk to people after this conference. Say, hey, even if they're your competitor, what are you doing to get your service capabilities improved? Are you looking at parts? Are you looking at part solutions other than the OEM? That's an obvious one. But what are you looking at as far as parts that aren't maybe a big box store? So we have some big box stores out there and they're kind of convenient. stuff, but maybe they're not the best solution. Every year, listen to your customers. That goes back to the survey, and no, don't do just an annual survey. The worst thing you can do, I think. We actually do a sample, by the way, of service reports. We do a sample, and it's automated from the system, so I have no play in it. Could be I help them figure out why their thermometer batteries were low. How'd we do on that survey? Develop your partnerships. Do at conferences like this, collect the business cards, follow up with those people after. And I don't mean just collect them. Don't go around the tables and just collect business cards. Talk to them here, follow up with them about that conversation, make some notes while you're here. But develop partnerships so you can pull it out of your Rolodex and say, oh, you know what? I found out one company is looking at breaking into Siemens tubes already here. Engage and develop your people, and then always, always, always reassess. Your initiatives might carry over from year to year. I'm going to share with you a couple of metrics, and this is COVID a little bit. Well, I got to remember what color this is. Compliance, quality. 100% quarter one. Quarter two, we didn't get all of our PMs done on time. Why? We were dependent on outsourced capabilities at that time, and we weren't managing them. The radiology department was kind of going, well, we're fine with whatever they tell us when they come in, right? Now, is that a good thing? No. How do I explain that? I don't have a good explanation. Nobody's going to want to hear me say, well, one of our vendors said, well, you know, this COVID thing, we're just not going to do PMs for a while. I got them on the phone almost immediately. That same day, they sent me an email. That was how they let us customers know they were making a choice for us, that they weren't going to uphold our contract. Then we got it back because we realized here we weren't even managing our own vendors, right? My imaging engineers expected to manage, they have PMs to manage the vendor to make sure that the vendor did the work. I wasn't managing it. There's maybe a lot more I could have done. And I can tell you that was also when we were doing a lot of other things. But what's interesting is safety is right here. We weren't managing our recalls. I mentioned that our safety metric is about recalls and cybersecurity. This wasn't a cybersecurity thing, but we were a little behind on looking at ACRE. We use ACRE. Why is that important? Well, ACRE likes to have 3 priorities, and we had some high priorities that weren't being accounted for. We didn't have a schedule for when we were getting updates or anything. And we can't blame COVID for this other than we just were slacking. And you notice kind of like generally everything went down except, and I thought this was kind of interesting, oh, maybe it wasn't safety. Safety was down here. On quarter 2, what is this? Well, safety didn't go down at all because I guess we were on top of it. I can't remember what drew our numbers down. Reliability. Oh, that's what I wanted to point out. I think that the reliability of our equipment started going down. I mean, if you do an annual PM and you do it well, sometimes everything is working just fine. And in imaging, sometimes everything's not. You realize, well, it's probably going to be a month or 2 before I have to replace that tube because things are passing today, but I can see the performance has changed. And I think that was part of it. I didn't spell out why. But anyway, these are some of the key metrics. You can put them all out there, but I wanted to put them up in one screen and show the correlation. The last thing I want to hit on is assess your staff and what your education planning is. If your staff have a strong educational background to begin with. Do you think they're going to be successful 10 years down the road? Now, I would love to hear somebody's opinion. Anybody? If they have their, let's say if they have their bachelor's degree in electrical engineering 10 years ago, do you think they're going to be a successful imaging service engineer today? It's a foundation, in my opinion. It's a foundation, but it is not going to keep them competent. You realize or you see, I didn't put a lot under education. Education is a formal program, academic program, right? It could be the military training school, it could be the community college, it could be the university. These trainings are very important. Their initial is how I think of these. OEM training, going to a training institute. I didn't want to say RSTI, but Training Institute is part of their name. Tri-imaging, I mentioned earlier, for example, technical prospects. Everybody's got some sort of training. Seminars. Don't forget to document. If it's a formal training that one of your engineers is going to give to somebody else, make sure that there's a syllabus. Make sure there are points that they're going to hit on the system. Even if, and quite frankly, I've done this. I've said, hey, walk through step by step the PM, and then document that you went through the PM. That's not a good substitution for the formal training like the OEM or the Training Institute, possibly the seminars. And OJT, we have our staff document OJT. It's not formal though. We've distinguished between formal training, where let's say you said, okay, today or tomorrow or next week, really more like a next week, we're going to do the Veradius. We're going to go through the Veradius PM together. This is probably the most important thing. This goes back to the 10-year example that I was bringing up, and that's assessment. How are you assessing your staff, their competencies today, and that what they knew back when has been used? They're still competent at it. Do they need to be competent at it? Who cares if, for example, I worked on some older pulse oximeters as an early tech. They don't even have them out on market. I haven't ever seen them. It's even less likely now because they're so old that I'd see them on a medical mission, right? It's not going to be very helpful, especially in the primary workplace. But some programs will offer some sort of renewal training. There are certainly things like certifications and licenses. Certain states have licenses for imaging engineers or something like that. They have to be qualified by the state to perform X-ray maintenance and services, like Colorado. It's not very difficult, but at least it's an assessment of what they know. I am a big fan of this, is renewal training. I look at what people have been trained on, and then I try to figure out if I can get them back to school, right? For something that, and it might not be a renewal, it may be an enhancement. Let's say, for example, I mentioned the Veradius. If they went to Pulsera school, we now look like we're going to get more Veradius in the system or whatever. We have the Veradius and then the new Zenition, right? Is that a renewal? Probably. It's a refresher. It is for Philips, for example. And then Chris, I think, left the room already, but feedback and repeat calls. This is a good assessment tool. If your customers are like, oh man, every time we call him, we love it. Every time you send the other guy, there's a disconnect. I think it's your responsibility as a manager, let's say, a director, or even as a coworker, to apply just culture and figure out the reason why, right? Is it unfair to send the ultrasound tech or ultrasound engineer out on an x-ray call when they don't work on x-ray very often at all, maybe out of school here or there way back when? Probably. He or she is not going to be as good probably at that call. So if the customer complains, you got to look at your program, right? I do think you need to look at and say, well, why did we dispatch that person, or can we do something better? But apply just culture, right? Is there a reason really why? Is it your process, or was it deliberate? It's probably never deliberate. Levels of competency that I go through, I will tell you, I look at this. There's a lot of people that will say I can do everything and they have nothing documented. How are you going to justify to your customers, internal, the hospital you're trying to sell, the imaging center that you're trying to sell services to, what you're competent on if you can't establish what qualifications the person has? Now, we've all had entry-level people that don't have that. That's fine. But if I'm trying to sell, and I had another OEM a couple of years ago try to sell me on the idea that they should be performing multi-vendor service on a CT from another OEM, one of the questions I asked was, who's trained from your organization and how were they trained? They don't have to be trained by X company, but how are they trained to perform service? And that they could not get me a response. They tried to undercut the price. I said, I'm not interested in the price. I mean, I am, but I'm really truly interested in how much time you're going to take to fix most problems. And then again, documented formal education or training is a level of competency, but somebody goes to school, that doesn't mean they're competent. There are some training programs out there, and I appreciate these ones that actually give a score at the end, tell you that you're not going to pass. I don't think I've ever been to one where somebody hasn't actually passed, but documented formal education or training is kind of the base. Are they capable of completing the preventative maintenance independently, right? Are they able to do the most fundamental work, but probably the most detailed work on that system? Now, these are harder. These are the kind of the gray areas, because you'll have people debate you if you're going through a development plan with somebody, if you're really trying to help them understand where their next steps in maybe their career is or with the organization. But there is some gray area. You can all probably imagine these things here, but are they able to provide moderate troubleshooting or highly sophisticated on most sophisticated problems? And how do you assess your vendors on this? I don't have a magic answer. I usually just jump to this, is that if they've been doing it for a while, and I know the engineer's been doing it for a while, because I do ask for the qualifications. If they've been doing it for a while, they're probably at this level. That 4-1, you could kind of get rid of it. And then 6, a little debatable. I've seen some organizations say, well, can you? And they'll ask the person, can you train your fellow coworker or whatever on that modality, on that specific device or whatever? I get feedback. We did for a while there. We actually did surveys, SurveyMonkey, and just sent a SurveyMonkey survey to technicians who were trained by another technician or engineer. I found with too small a group, it just didn't, there was no true anonymity. So I gave them that anonymity in the sense of let's talk, let's find out what your thoughts. Do you feel like you can go and do a complete PM with, those next steps? Can you do the complete PM today, or do you feel comfortable doing it a couple of times with another engineer before saying that the senior engineer, let's say, or the more veteran engineer has a demonstrated ability. Demonstrated is the key, right? That's the person that usually you already know they're going to be able to demonstrate it. But there are some folks out there that may not ever achieve this. And very honestly, I don't put them in this category if they can't teach it. They might be the best at level 5. I could probably put them in front of anything on that particular modality, general biomed, imaging or whatever, but if they can't teach it, it's not a fault on their part. So 5 and 6 are pretty good, but it's not necessarily a fault on their part. They just may not be good teachers, right? Or they may not feel comfortable telling somebody else how to do it. But a 6 is like the gold star. Assessing your inventory real quick. Get on the capital equipment planning committee if you're not already on it. Don't allow, which I did, don't allow your boss who doesn't know medical equipment to be on the capital equipment committee. Don't think that if you're an ISO or a multi-vendor or an OEM service that you shouldn't figure out who is on that capital committee if you're doing time and materials and contracted only services and saying, hey, clinical engineering manager, materials management director, chief financial officer, if you need any help, we're here to help you, right? Now, you got to look out sometimes for the wolf in sheep's clothing. They come in all forms. I've seen OEMs come in and say, well, that's going to be end of life. You're going to want to buy a new one. It's like, really? I've seen spreadsheets that everything was going to be end of life this year. It's like, so show me the letter. Oh, our spreadsheet's a little mixed up. You wanted to present that to somebody? I've also seen biomeds say, well, we should just get rid of that, right? It's a piece of junk, end of life. Well, there's other ways to measure that, right? And to prove that. But those same wolves in sheep's clothing could be in the capital equipment committee. They could also be, well, it could be the director of radiology who's in the capital equipment committee and says, oh, you would not believe we have so much downtime on this piece of equipment, right? We need to get a new piece of equipment. And then, fortunately, if you have the relationships, either as a in-house program or you're contracted to be their in-house advisor, if you have the relationships, hopefully somebody comes to you from the capital equipment committee after the meeting, maybe even during the meeting. It's a little awkward when this happens, but during the meeting when they ask you, so what do you think? Do you have a history of that system being unrepairable or down a lot? No, or hold on, I got this little maintenance management system. While you guys proceed to hear the next justification for X, Y, or Z, I'll pull it up. I'm surprised to hear that. Hold on. Nope, not a history. I'll take that offline with the radiology director, right? Find out if there's something we're missing. Maybe we don't have a document or something. Again, just culture. Got to make sure that you're not slitting your own throat. Life cycle planning. I think this is a big opportunity for our multi-vendor ISO and OEM partners. Sometimes they have a lot more history than we do as smaller organizations or regional organizations or national organizations for that matter in healthcare, because they've got a bigger install base. But again, wolf in sheep's clothing, you got to worry about that. Utilization, I'm really excited about tools that are also cybersecurity tools. I can tell you I've been using a little bit of these to my advantage more than all these disparate systems to see how well one tool order, for example, a couple of them do this, will tell you how many scans I think we got from our Siemens CT, we got actually some diagnostic error code information from how order was thinking. I think it was their CT. Anyway, look at utilization. This should play into, are they actually using it? Do you really need to buy this if dollars are tight? Do you really need to buy this CT, or is it really the research CT that's underutilized right now because all the researchers are onto something else? They're doing research in MR ablation. Think about your updates and upgrades. How many of you know what is available? What is available as far as upgrades for your imaging systems? Let's take for your MRIs that basically make them a new MRI, at least for another 4 or 5 years. Do you know today on your inventory, however big it is, do you know how many of your systems there is a 150K upgrade that might prolong the life instead of replacing the, let's say, $1.2 million magnet? Think about those things. Think about what your updates and upgrades plan is. I'm not talking necessarily about OSs and that. You can scare a lot of people in capital equipment when you say, whoa, it's running Windows 7. We've got, well, some systems, Windows XP. We have got to replace this right away. I don't like to pull that trigger myself. I think, and pardon me, I didn't get if anybody hears from IT, but I've heard that a little too much from IT. It's a scare tactic. It's not always the case. And look at your service and recall history. Is that thing going to start really causing you problems? Again, we measure service safety events and things that are reported or identified through CRES. That's the tool that we use. But look at your service history. Is it failing? I've already kind of mentioned this. Is it failing, and is it repeatedly failing, and is it something that can't be prevented or can sort of be prevented, but it's just going to start aging out? This is coming from a guy that kept a car alive for way too long on the personal side, right? And my guys used to laugh at me. I'm like, but I wouldn't do the same thing to the hospital because it's a little bit for me to work on it on the weekends, and I've got another car. I can borrow my wife's car, but I'm not going to do the same thing with, let's say the one C-arm that's your problem child, right?